Good morning, students. This is Dr. Lawham, and we are going to talk a little bit today about some of the preliminary information that you'll need in class when we go over our case study regarding peripheral arterial, peripheral venous, and lymph disorders. So I wanted to help you to sort of pull together some of the information ahead of time that you've already learned in your other classes, and so that you'll be ready when you get to class to review these disorders. So our student learning objectives, which are going to look pretty similar as we assimilate the information that you have already learned coming into this class, you're going to utilize that, especially assessment being one of the most important things that nurses do, constantly assessing, in order to utilize the nursing process as a framework for developing a thoughtful care plan for your patients based on a patient-centered approach. We also want you to be able to compare and contrast the various diseases so that you can see and understand the differences between, say, arterial disease versus venous disease versus lymph disease, and identifying those critical complications and what a patient would look like if they were having those complications. This is hugely important in the clinical setting, especially because we are the people, the stopgaps, and if we can't identify the complications and know what to do, then that's when harm comes to our patient. So we are talking about arterial, venous, and lymphatics. Remember, your arteries deliver oxygen to the body. Your venous system delivers the blood back to the heart to be reoxygenated, and in the same token also delivers CO2 back into the system to be exhaled and eliminated. And then your lymphatics are hugely important in terms of infection and infectious disorders. And helps to remove bacteria and such out of the body. So very important systems, all of them. And when they are blocked, we then have problems. So, and I would again, whenever you guys hear me talk, you're going to hear me say, if you get a test question, start with what you know. So if you know what the arterial system does, or you know what the venous system does, and the lymphatic system, and the ramifications therein, if those systems aren't functioning, then you can understand what the problems are, right? If you understand that there are issues with regard to oxygenating the body, then you start to have tissue perfusion problems, right? And so forth. So again, be thinking of it in terms of that. So really all of the issues, well, I shouldn't say all of the issues. When we're talking about arteries and veins, and we start to see problems with those, often the issues begin with arterial sclerosis and atherosclerosis. So, and what those amount to, and again, I always encourage you guys to put your pathos in your own words, 1 or 2 sentences. But what it is it's a process of sort of narrowing and thickening of the vessels, thickening of the muscular layer around the vessels, and again, the narrowing results from accumulation of lipids and calcium and carbs and fibrous tissue and bloody plaques that sort of accumulate on the insides of the blood vessels. Often what helps this along is when people develop high blood pressure or there's increased pressure within those vessels, they actually start to have injury from that increased pressure, hypertension, right? And so what happens is where those injuries occur in the blood vessels, that's where the accumulation of the lipids begins, and the calcium and all those other tissues. Our body's always trying to stop up any kinds of bleeds or, send healing factors to any injuries. And what happens is that area becomes sticky, and that's when the plaques and the fibrous tissue and all of that begin to stick on the intima of the blood vessels. And that results in stenosis. Stenosis is blockage. Okay, when something is stenotic, it's narrowed and or even becomes obstructed. Also, what can occur as a result of this is aneurysms. Aneurysms are a weakness in a arterial wall, and that results from, again, breakdown and or injury to the lining of the vessel, and plus increased pressure due to narrowing of the vessels and hypertension and so forth. And those aneurysms can actually rupture, which can be life-threatening, depending on the vessel, and or cause things like strokes and whatnot. Also, this process, this arterioatherosclerotic process, can cause ulceration if tissue perfusion is a problem. So, our risk factors, some are modifiable and some are not. Smoking, sedentary lifestyle, high fat, high cholesterol diets, hypertension, hyperlipidemia, diabetes mellitus, an elevated C-reactive protein, which is a inflammatory marker, hyperhomocystinemia. Homocysteine is a factor that we have in our bodies, and if you have too much, again, that tends to encourage this inflammatory and atherosclerotic process. Where there's inflammation, when there's inflammation within the blood vessels, it will cause increased accumulation of lipids and all of this other stuff and stenosis. Also, the older age, female gender, and genetics can increase. Those are all risk factors. Your clinical manifestations, of course, it depends on the vessels affected. You know, if we're talking about arterial kinds of things, there's more likely to have intermittent claudication, which is, you know, pain, say in the legs when people are walking and they stop and rest and the pain goes away. And it's just because there's more demand than there is supply in terms of oxygen, because the vessels are narrowed and the oxygen can't get to the legs and to the muscles. Chest pain, maybe shortness of breath on exertion, maybe stroke symptoms, and so on. There are lots of different clinical manifestations. It all depends on where this is happening. So this just shows you sort of a pictorial of the pathophysiological progression of atherosclerosis, where you can get some inflammation inside the vessel, and it even shows you over a time frame, and you start getting the buildup of fatty streaks and plaques and so forth. It's a real dance of different things that go on, and at the other end of the spectrum you see the outcomes, that people can have heart attacks and strokes and can develop ulcers that lead to gangrene and so forth. These are your common sites of atherosclerotic obstruction, often in places where there are big major curves, where there's a lot of, where pressure from increased blood pressure and such could actually cause more injury. Anyway, just for your visual pleasure. And this just shows you sort of the comparison of an artery and a vein. Okay, your arteries have a much thicker muscular middle section, and again, there's a lot more pressure that goes through the arteries than goes through the veins. Okay, the large arteries have very thick walls, and they're very elastic. In that elastic property, it cushions the impact, the pressure, by that ventricular contraction, because that left ventricle is a very strong contraction, provides recoil that propels blood forward into the circulation. Large arteries also contain some smooth muscle, and we're talking like the aorta and the pulmonary artery. And we talked about the endothelial lining. You see it on both, and it serves to maintain hemostasis, okay, and promote blood flow. And under normal conditions, it does inhibit blood coagulation. But if that surface is disrupted, if there's too much pressure and there's injury, or there's plaque and whatnot, the coagulation cascade can be initiated and a clot can develop. Capillaries are thin, walled little vessels made up of endothelial cells, no elastic or muscle tissue. They have thin walls so that there can be an exchange of nutrients and metabolic end products more easily. These thick arteries are thick for delivery purposes and to be able to withstand the pressure. Capillaries, we want them to be able to exchange nutrients and metabolic end product. Capillaries connect the arterioles to the venules, okay? The veins are large diameter, thin-walled vessels that return blood to the right atrium, okay? So the venous system is a low-pressure, high-volume system. The larger veins contain semilunar valves at intervals to maintain the blood flow towards the heart. So in other words, it's sort of with a pump, those valves open and then they close so that the blood doesn't go backwards. The amount of blood in the venous system is affected by so many things, including arterial flow, compression of the veins by skeletal muscles, alterations in thoracic and abdominal pressures, as well as the right atrial pressure. The largest vein, the superior vena cava, returns blood to the heart from the head, neck, arms, and the inferior vena cava, which returns blood to the heart from the lower part of the body. So just to give you that sort of review. So here's where some of our nursing knowledge is important now. We as nurses have to be thinking about risk factors for different diseases, because the modifiable things we want to help the patients with. So we have our non-modifiable, age, gender, family predisposition, and genetics. We can't do much with that, can we? But we certainly, as nurses, can help patients deal with these things on the left-hand side. Smoking cessation, educating patients about eating a healthy diet that includes, low fat, low sodium, low fat proteins, and lots of green leafy veggies and those kinds of things. Control of hypertension, encouraging patients to take their medications, controlling their diabetes, obesity, trying to eliminate that, which would often eliminate diabetes and hypertension. Stress reduction, sedentary lifestyle, all of those things are modifiable risk factors that increase the risk for atherosclerosis. C-reactive protein, as I said, it's a substance that you will see in high amounts in the blood when people have, in inflammatory situations. And so again, controlling a lot of these other modifiable factors will help to decrease your C-reactive protein. Hyperhomocysteemia also increases the risk for atherosclerosis. Sometimes that is familial, and sometimes it is just, again, related to a lot of these lifestyle issues up above. So trying to have them have homocysteine levels checked and that sort of thing would be helpful. So we're going to start our discussion with the peripheral arterial vascular issues. And then we'll move, and we're going to just go over some real quick stuff, hopefully, that you've already had. So vaso-occlusive would be your pulmonary artery occlusions, or peripheral arterial occlusions, I'm sorry, got pulmonary artery on the brain here, which could be emboli or thrombi. Do you guys know the difference between an embolus versus a thrombus? Emboli break off of thrombi from other places. So in other words, an embolus usually is a traveling thrombus. Aneurysms, and again, considering aneurysms more of a complication, and we're going to learn just a little bit about what they look like and how you might identify it, but the treatment of such will be talked about in 415. And then the more vasospastic issues. So we've kind of talked a little bit about the patho already, kind of where these things begin. regarding blockage. So when we get occlusive disease, that is a partial or full blockage of an artery, usually below the aorta and renal arteries, and it's often related to athero or arterial sclerosis. Arterial embolus or thrombus is occlusion of an artery occurring from some sort of iatrogenic, meaning unclear injury, or when drugs of abuse are repeatedly injected. That can happen as well. Also can come from crush injuries, fractures, and other trauma. And we also see these thrombi in people with atrial fibrillation, because when the heart is beating irregularly, blood can pool in the heart and it will clot and send clots through the body. So as I said, and again, the embolus versus thrombus, it's the same risks. Irregular heart rhythm would be an additional risk for a thrombus. Things that cause thickening of the blood can cause these things as well. Those are all potential risks. Situations where people are at risk for an embolus or a thrombus. So irregular heart rhythms and things that cause thickening of the blood. Pregnancy is a time when people's blood is hypercoagulable, especially at delivery time. And so occasionally, unfortunately, we do see females after having babies who maybe develop a DVT or throw a blood clot into their lungs. So clinical manifestations. Intermittent claudication, which is aching, cramping pain, which induces fatigue and weakness in the legs, and it is relieved by rest. The legs hanging down feel better, and if you think of it, that makes sense because you're allowing gravity to help deliver oxygenated blood down to the leg muscles. Now, if somebody had a venous problem, the picture would not be this way, right? Because the venous, hanging your legs down, actually worsens edema and worsens circulation. People who have venous problems, we actually raise their legs. So just something to think about. Elevating the legs would make people with these problems feel worse. What other things nurses will see? Unequal peripheral pulses bilaterally. You'd feel one would not feel like the other. One would probably feel weaker, the affected side. The affected side would feel cool with poor capillary refill, maybe even skin and nail changes where they get kind of leathery looking and there's no hair, maybe growth on that extremity. Muscular and skin atrophy, poor hair growth, as I said. And the 6 P's: pain, pallor, pulselessness, paresthesia, poikilothermia, that's basically coolness, and paralysis. So this picture, I have a picture coming up that will help you to see that. This is a picture that just shows you that intermittent claudication and where the arteries become narrowed and where you may see some of the, pulse weakening and so forth. This is this has 5 P's, but we added a 6th P, that poikilothermia, so you get the coolness as well. But this just helps you to remember that neurovascular assessment, and if you assess somebody's lower extremity and the 6 P's are noted, then you need to be concerned that maybe they've got some sort of partial or total occlusion. Okay, so some of the complications of peripheral arterial disease and such, and their characteristics. You have arterial aneurysms, which you can kind of see a bulge here. These are some of your types of aneurysms. You don't need to know that. This is nice to know information. And I show you pictures just so you can see a bulging area and dissection of an artery. You'll hear the term aortic dissection in 415, which it can be a life-threatening situation where you can actually see the outer lining separating from the endothelial lining of that vessel, and the blood kind of tries to circulate in between, and that weakens the vessel. Understand that aneurysms are a weakness and dilation that forms in an arterial wall. often, again, related to hypertension and arterial sclerosis. And when patients have these, they can often feel kind of a pulsating in the area of the vessel, almost feels like it's beating. People can have these up in their necks. They can have these down in their abdomens. Most of them seem to be down there. But they almost will say that they feel like they have a heartbeat. Otherwise, there's not much. Sometimes these can be, aneurysms can be familial. So there can be a familial weakness in a vessel kind of thing. And if you ever hear anybody say that somebody died suddenly from an aneurysm, that patient may need to have evaluation, because there are things that they can do to remove that risk. And this is your dissection, which is a sudden, severe kind of, they will feel. This dissection, aortic dissection particularly, it's a ripping, severe ripping pain that extends to the back and the shoulders and the epigastrium. They'll have some neurological and cardiovascular symptoms. They will be tachycardic and sweating. And of course, the risk of this rupturing is very, very high. The risk factors for the dissection kind of thing can be congenital weakness in the aorta. It can be blunt stress trauma, hypertension, again, athero and arterial sclerosis, cocaine use, tobacco use, and it tends to happen in men and women between the age of 50 and 70. You don't need to know about these dissections this semester. I'm just showing you what can happen and how you might recognize it. So this gives you just kind of the worst of the worst kinds of things. Anybody with atherosclerosis could develop, or arterial sclerosis, MIs and strokes and kidney failure and syncope is passing out, and occlusions and aneurysms and such. And this just takes you down through. I mean, they all look pretty much the same, don't they? That all of these things can cause big, major problems, okay? Emboli can cause heart attacks and strokes, because if you have a deep vein thrombosis in your venous system, you can break off clots from that, which can go to the lungs and develop emboli there. An occlusion an embolus can reoccur. People can develop compartment syndrome, which you'll learn about later when we talk musculoskeletal. And then Raynaud's phenomenon, which we're going to get into in a second, and what that is all about in terms of being a vasospastic disorder. Raynaud's is not an occlusive disorder, it's a vasospastic disorder, where the arteries vasoconstrict, and that results in that same sort of pallor and coldness and pain. It can be primary or idiopathic, meaning there's no other cause to it. They're not sure why it happens. It just may be familial. Or it could be secondary to an autoimmune disease, such as systemic lupus erythematosus, or an arterial obstruction or a trauma or something like that. But what happens is people will get, often cold and stress are the big triggers, and they'll get this sudden vasoconstriction in their hands that results in their hands turning different colors, basically white, blue, and then red, and they get numb and tingly and they burn and they feel very uncomfortable. This can happen in the toes as well, and often it is bilateral and symmetrical. And they can have hyperhidrosis, which is significant sweating. It's triggered, again, by emotional sensitivity to temperature changes in the environment, often the cold. You see this a lot in women, age 16 to 40, folks who've had some sort of a trauma, obstructive lesions, or, as I said, the autoimmune disease. And here are some pictures just to help you to kind of visualize this whole thing. You can see the red, white, and blue. They go white first, often very white, and then kind of bluish, and then as the vasospasm resolves, they get very red again. It doesn't last too long, and these are, of course, extremes. Ignore this picture of aortic dissection. That shouldn't be there. It's believed that Raynaud's is a defect in the basal heat production, so body heat production leading to this cutaneous vessels being unable to dilate. So really the whole treatment for this, and we'll learn about this later, is really to protect people from the cold and other triggers and avoid injury to the hands and fingers. All right. So laboratory tests, and you guys have learned a lot about laboratory tests already. You know about lipids and glucose and hemoglobin A1C. Lipid panel tells us about cholesterol levels and levels of good and bad cholesterol. Glucose and hemoglobin A1C for diabetes. BUN creatinine, 24-hour urines and UAs can tell us something about renal function, make sure there's no infections and things like that. Again, C-reactive protein, which I've mentioned before, is a sensitive marker for cardiovascular inflammation, just in general. Homocysteine levels, again, associated with increased risk of cerebral vascular, peripheral, and coronary artery disease, and venous thrombotic embolism types of disorders. Some people have high homocysteine levels simply from family history. Factor V Leiden is another. It's a very specialized test. Again, you don't have to memorize that. It's associated with genetic predisposition to emboli formation. People who have elevated Factor V Leiden will, they'll often check these tests after people develop blood clots to see if they have such, familial tendencies. And then the diagnostic tests. Now, these are all in that cardiac chapter. And what you need to know, what you need to look at is, what do I need to know about these things? Okay? Are there preps involved and those kinds of things? As a nurse, that's kind of what we're thinking. Yes, it's nice we want to know what kinds of information it will tell us, like Doppler flow studies, which really there's no prep, it's not invasive, and they just look for architectural abnormalities and look at flow, the blood flow in an area. Exercise testing, and you guys know that, are really good in terms of measuring the heart and the circulation during exercise. Duplex ultrasound, again, like a Doppler flow study. Now, CT angiography and scanning, you'll remember that with CT scans, there's often a contrast media that is iodine type based. So people with iodine or shellfish allergies need to know about that. We also need to know anytime anybody has any of that angiography, a CT angiography or a CT scan, anytime they get contrast media, we need to be increasing fluids afterwards and watching renal output, because renal function is an important thing to be observing afterwards. People who have renal disease may need to receive acetylcysteine, which is Mucomyst, to help to deliver that contrast media through the kidneys and out of the body. That kind of thing. So that's important for nurses to know. So obviously a BUN and creatinine, it would be an important test for a patient to have done before they have a CT scan, so that we are delivering contrast media and shutting down their kidneys, because that could result. But your angiography actually looks at the circulation picture, provides a real nice picture of tissue perfusion. An MRA, again, very similar. It's similar to MRI, but its images look a lot like angiograms, and they can be 3D. But it is a magnetic resonance angiogram is what it is. So people who have metal implants, just like for people with MRIs, people with metal implants, old tattoos with trace elements, people with any kind of metal in their body, it would need to be a different kind of test. You'd want to bring it to the attention of the provider. Sometimes they also use IV contrast with these tests, so again, important to know allergic considerations as well as renal function. The ankle brachial index is a test calculating the ratio of the systolic blood pressure of the ankle with the systolic blood pressure of the arm, so it helps to quantify the degree of stenosis in the vessels. And I've got a picture coming up of that. And then another, I didn't list it here, but another type of test you might see is a transesophageal echocardiogram. Sometimes they'll do an echocardiogram just like they do any ultrasound, just on the top of the chest. But if there is concern about valvular disease in the heart, or to get a more thorough view, they'll do a transesophageal, where the patient is sedated and they go down actually through the esophagus, and they do the ultrasound from behind the heart. And so risks to the patient of that type of procedure, of course, just like with any kind of esophageal, like an EGD kind of thing, would be aspiration, respiratory depression, esophageal perforation, vasovagal stimulation during the test. So just some different things to think about. So angiography, these are just some pictures for you to see of just what kinds of things they look at. And this is your MRA. This is a continuous wave Doppler ultrasound where they can look at and detect blood flow. With the computation of the ankle and arm pressures, they can kind of do a thorough analysis. And then the last but not least here is your ankle brachial index, ABI, and this is kind of what it would look like. You don't need to know how to interpret any of this. This is just for your information. I'm moving forward to the peripheral venous disorders, but I brought this slide up because I want to make it very clear that you want to be able to compare and contrast patient symptoms and be able to identify what's arterial versus what's venous. As this says, the pain gets better if I dangle my foot off the bed. Elevating my feet makes the pain worse. That's arterial, right? Your venous will actually feel better with the leg elevated. So it just gives you sort of a idea of what you might see in these patients. So peripheral venous disease includes disorders such as varicose veins, venous thromboembolism, chronic venous insufficiency, post-thrombotic syndrome, which is and then leg ulcers. Your varicose veins, often varicosities are a family history kind of thing. If a lot of people in your family have them, you probably will have them too. And it's usually without deep vein involvement. Occasionally you can have, that's primary varicose veins. Secondary can be secondary to obstruction of deep veins. That can happen as well. But the varicose veins results in reflux of blood and venous stasis. So you get, you have these veins that are just big, and the valves in the veins that keep the blood going forward often are leaky, and so the blood kind of flows back before it moves forward. So it results in these just large vessels. And that can put people at risk for venous thromboembolism, which can occur from endothelial damage, venous stasis, which you get from your varicose veins, or altered coagulation, such as with pregnancy, trauma, things like that. And you already know what a thrombosis is, but again, can happen from all kinds of different things, whether it be surgeries or central venous catheterizations, dialysis, any kind of vein damage, repetitive motion injuries, and things that cause venous stasis, such as bed rest or immobilization, obesity, varicosities, spinal cord injury, or even just greater than age 65. Situations where there's altered coagulation, as I said, pregnancy, cancer, oral contraceptive use, and people who have some of the defects that can be from genetics, genetic predisposition to protein C deficiency, protein S deficiency, antiphospholipid syndrome, factor V Leiden I told you about, hyperhomocysteine, elevated clotting factors. There are lots of different things. Polycythemia, where you have lots of blood vessels per ml of blood, you know, where you have, again, it causes thicker blood, which can result in emboli. If you just think about that, it sort of makes sense. Your chronic venous insufficiency is basically chronic distension of the veins, preventing the valves from fully closing, causing a backflow or reflux of blood in the veins. You've probably seen this with folks. Your leg ulcers, I think you guys already understand that, where you get alterations in the vessels and the arteries, capillaries, and veins, mostly secondary to the chronic venous insufficiency, results in inadequate oxygenation, nutrient exchange, and it ends up altering skin integrity because the area becomes necrotic and inflamed, and the dead skin causes an ulceration. The post-thrombotic syndrome is it's essentially venous insufficiency that occurs after someone's had a thrombus, which puts them at higher risk for having another thrombus. So we talked about these issues already. This just shows you sort of the function of the valves. Normally, blood, you know, as the heart pumps, blood flows through, and then the valves close, and then the heart pumps again, and the blood keeps flowing up. But when people have venous insufficiency, these valves get kind of weak and or inefficient, especially if there's too much volume, and blood goes up and down. And so you get essentially this kind of swelling and stasis of blood. Virchow's triad, which we're not going to talk about a ton this semester, but this is a triad, 3 things that put people at risk for blood clots: hypercoagulability, stasis of blood flow, and endothelial injury. That is the triad that we often see for people who develop blood clots. And anyway, these are just some pictures of people with significant chronic stasis, inflammation, and problems. This shows you some varicose veins, again, chronic venous insufficiency, and some of the changes that you'll see, the skin texture changes where you get that brownish color to the skin and no hair growth and such, and then ulceration. So, again, and your clinical manifestation, what does your patient look like when they have a thromboembolism? Take a look at this picture, right? In the affected limb, you'll have a firm, edematous, warm, erythematous area. So swollen, red, warm, painful. It's painful to walk on or weight bear. It hurts to palpate. You don't want to be palpating this, folks. You also don't want to be dorsiflexing the foot because that could cause alteration in that clot and or movement, and you don't want to do that. Risks: venous disorders, hypercoag, cancer. We already talked about the risks. You can review those things. Again, we've talked about chronic insufficiencies and what your patient is going to look like, therefore, with these venous insufficiencies. They can have varying degrees of swelling and edema in the legs, altered pigmentation, pain, stasis dermatitis. I don't know if you can see kind of a peeling of that skin. And it can be debilitating. People are really uncomfortable when they when their legs are hanging down like that and or they're walking because the blood pools down there. Varicose veins, again, some people will have dull aches and pains from their varicose veins or fatigue, muscle cramps, and their legs will feel kind of heavy. But these feet will not feel cold like they do in peripheral arterial disease. They'll be warm. You'll see the veins kind of bulging. If they have a DVT, obviously we talked about that being quite painful and such. You'll see pigment changes sometimes, etc. Some people will have sort of little spider veins. Others will have really these tortuous looking, bulgy venous varicose veins. And then your leg ulcers, which can differ some. I feel like it's important for you to understand the underlying process of arterial versus venous and why they occur. They're kind of occurring for different reasons. Your arterial leg ulcers tend to be small, circular, they're deep, caused usually by ischemia or pressure. I mean, the arterial are because they're not getting enough oxygen. Your venous are, again, the leg is more achy and heavy and swelling and all of that kind of thing. You don't get the same kind of swelling with arterial ulcers. Superficial and exudative. Often there's discoloration of the skin around it, but I think what's more important is to be able to identify skin that's beginning to break down and understand that when people have peripheral arterial problems or peripheral venous problems, that they are at risk for these things. I'm not going to ask you to get into knowing the difference between an arterial ulcer versus a venous one. So based on the risk factors is how you would go about looking at your lab values. We've talked about labs already, and based on the areas of the body affected. If you have somebody who's got atherosclerosis, arterial sclerosis, we're going to want to know what their kidney functions are. We're going to want to know what their glucose and hemoglobin A1C are, because do they have diabetes on top of it? Is that what sort of started it? Remember that diabetes enhances and increases the risk and or the speed at which people develop these plaques, because people who don't have good control of their blood sugar often have sticky vessel walls, and so the lipids and all the other things that we said stick to the vessel walls, the plaques, just do it even more quickly. So think about what you might want to see done for people with these kinds of different problems. Often, we've already talked about people having Doppler studies, flow studies. Obviously, those would be something that these people would have done. But they may also have to have, CT scans to assess the extent of some of the tissue damage. It all depends. Depends on their family history and that kind of thing. You may be seeing blood tests looking for some of those tests that might indicate a familial disorder, for blood clots or what have you, especially in somebody who's otherwise healthy. A pregnant woman who has a pulmonary embolus postpartum, they would probably be looking for the factor V Leiden and the protein C, the protein S, and so forth, because they're going to be looking to see if there was an increase, something else that pushed their risk over the limit. And these are just some of your more likely complications from these things. Your leg ulcers, obviously infection in any of these things, infection and cellulitis really can occur. There's a lot of overlap here. We know with leg ulcers, people can have to have amputations. They can develop neuropathy because as you get necrotic tissue, the nerves get damaged as well. Varicose veins, as I've said, put people at risk for DVTs, chronic venous insufficiency, post-thrombotic syndrome, all of that, and the ulcers. So it can all start with these varicose veins. So we need to help people, hopefully, to do things to prevent it from spreading into a DVT, leg ulcer, and all these other things. Anyway, I am going to move forward one more slide. I just wanted to show you this. Nursing Camp is actually something I think you can sign up for online. They have a lot of great slides, but I found this one, and before it makes your head hurt, take a look at it, because I love that it includes a lot of the different concepts that we've already talked about. It talks about deep vein thrombosis versus pulmonary embolism, and it talks about the differences. It talks about ways to decrease, the 3 reasons people will develop a clot, that Virchow's triad. So it talks about those kinds of things. It talks about what it might look like, what labs you'd want to monitor. So I thought this might be interesting to you. In terms of deep vein thrombosis, you'll see when we talk about treatments in class that we often are monitoring prothrombin time, partial prothrombin time, platelets and such, and pulses, simply because we are administering anticoagulants. So anyway, just some things you might anticipate happening. So just for I don't want you to get too much of a headache looking at it, but I thought this might be helpful to kind of pull it together a little bit. I'm jumping around because I'm really wanting to just stick to doing the patho and just some of the labs, things that you've already talked about in other classes, trying to pull these concepts together for you. So the lymphatic disorders are different from the others. Obviously, these are in the lymph tissue or in the lymph vessels versus in the blood vessels. There are 3 different disorders that we talk about. There's lymphangitis, which is acute inflammation or infection of the lymphatic channels, often secondary to a focus of infection in an extremity. There's lymphadenitis, which is inflammation or infection of the lymph nodes. That tends to be more common. And then there's lymphedema, which is tissue swelling related to obstruction of the lymphatic flow. It's either a primary problem where there are congenital malformations, or a secondary, which is an acquired obstruction. Maybe somebody had surgery, somebody had a mastectomy. That's why with our mastectomy clients that you never do a blood pressure on the affected side. If they had a bilateral mastectomy, then they get their blood pressure checked in their leg, because we don't want to mess with and or cause a flare-up of lymphedema. And you can see here, this shows you a picture. I don't know if you can see the swollen gland here in this young person's neck. And also you can see the lymphangitis here that developed. And you can kind of see that line going up to the heart. In terms of that lymphedema, it's not just with mastectomy, but even lymph node removal or biopsy or dissection can cause that kind of thing. Can also become obstructed if somebody has an abscess. It can press on the lymph. You can have a tumor or something pressing on a lymph vessel that is blocking the flow. You can see some pictures here of folks who have had lymphedema problems. This is a before and after treatment. They treat lymphedema with some different things, which we'll talk about. Often compression is the big thing. Your clinical manifestations and risk factors, of course, for your angitis and your adenitis infection for sure, and inflammation. Lymphedema can also occur as a result of infection or inflammation. Tissue swelling in lymphedema is most often unilateral and caused by an obstruction, though. But infection and inflammation can cause obstruction. So that's why people who have had any kind of lymph node surgeries resulting from other surgeries or damage to their nodes, you shouldn't be even doing blood tests on them on that side. Shouldn't be poking their fingers, because they could, anything that could cause a little localized inflammation can cause lymphedema. Let's see, your lymphangitis, the difference between that and adenitis is the red streaks extending from an infection on an extremity, whereas your lymphadenitis is that swollen red tender lymph node or lymph nodes in a localized area, usually associated with infection. All right, well, that's it for now. I'll see you in class, and we will talk some more and go over some cases and go over nursing care of these patients. Thank you.